issues, please.
So, Dr. Santoso, obviously you're not going to leave the stage until I find out how does the men get it in the first place.
I'm blushing.
Thanks for tuning in to Conversations with Betty LaMarr, coming to you live from the Bluff City. And now, your host, Betty LaMarr.
I'm your host, Betty LaMarr. And I have with me, I call him my medical mentor, Dr. Joseph Santoso. And today we're going to be talking a little bit more about obesity. But what we're going to do now, we're going to connect obesity and cancer. We're going to talk about nutrition. We're going to talk about post-surgical pain. We're going to talk about everything and anything that you need to know about that. Because again, you should make your health your number one priority. Good evening, Dr. Santoso, and welcome back to On Cable Tonight.
Thank you, Ms. LaMarr. Always a pleasure to be here.
It's always a pleasure to have you because we know one thing for sure. When you're on the show, we're going to learn something. I always say the only way you don't learn something on Medical Talk is that you don't want to learn anything. So let's go into this. First of all, for the people out there that may not know Dr. Joseph Santoso, tell us a little bit about Dr. Joseph Santoso, and then we're going to go into our topic of discussion this evening.
Sure, be happy to. I am a GYN oncologist, gynecologic oncologist. That means surgeon for cancer in women. I'm a professor at University of Tennessee. Also work at the West Clinic, or now we're changing it into West Cancer Center, and have been in Memphis, Tennessee since 2001 and loving it.
Okay, well, we'd love having you here. Okay, now, class is now in session, of course, with Dr. Joseph Santoso. You know, we treat this like a class because we're here to learn what we need to know about our health and wellness. Now, let's talk about this first. What is the link between obesity and cancer?
There are many cancers now are associated with overweight and obesity. The three most common, I'm dealing and taking care of women most of the time. The three most common cancer in women, postmenopausal breast, colon, and uterine cancer are all associated with obesity. How does that work? There are many theories. One of the theories is when we're overweight, we have enzyme called aromatase in our fat layers, especially abdominal fat. And that enzyme produces excess estrogen, hormone called estrogen. So when you're overweight, it's almost you're taking estrogen pill days in and days out, and we know that's not good for us. Because when you do that, then you stimulate the uterus to grow, and eventually become cancer. So in my practice right now, I'm seeing 6 to 8 new patients a week with this kind of cancer.
Well, what is it about the, I guess you would call belly fat that triggers cancer? Why the belly fat?
It's because the location of the enzyme called aromatase, and that's what induces the hormone. Interestingly also, I don't do breast cancer, but we know that many of breast cancer are estrogen receptor positive. And that's because the breast cancer in those populations also stimulated to grow, because when you're overweight, you produce excess estrogen. In many cases, your oncologist may prescribe aromatase inhibitors specifically to inhibit that enzyme to work producing estrogen. So to me, it will be relevant to you as a patient if I were having breast cancer with estrogen positive receptor type, I would try to lose weight as well.
Okay, so are the majority of the patients that have cancer in the gynecologic area, are they mostly overweight patients?
In uterine cancer, mostly are overweight. You're correct.
Okay. Well, what about, okay, we talked about this before. You said men with the waistline, and I said the belly. So does men that are overweight, are they also, what's the word?
Increased risk.
Do they have the increased risk of cancer also?
They do.
In what area?
Colon cancer is one particular cancer that has been associated with being overweight. Prostate cancer, and there are some other cancer that increasing in that aspect.
Okay, so what does the fat have to do with the cancer?
There are direct and indirect. For example, for uterine cancer is pretty clear. It's estrogen directly related. There are other cancer that I don't really take care of them, but what I learned is, for example, like esophageal cancer, they may have, when you're overweight, you may have increase of gastric reflux, and that irritates the mucosa in that area, and irritation leads to inflammation, and inflammation leads to cancer. So there's a direct and indirect, and there are other mechanisms that we're not clearly understanding, but we'll start learning more. One of the hormone that I'm very fascinated is called IGF-1, insulin growth factor 1. When we take excess calorie, we release insulin as well as insulin growth factor 1. And in mice and in vitro, at least we learn when you have excess of that, your cell proliferate much faster, and to the point that some of them become cancerous. In some of the cell studies, breast cancer, for example, when you induce IGF-1, they become less responsive to the usual chemotherapy. So in other words, excess calorie in that particular research associate with chemo-resistant. So your cancer cannot be treated as well.
Okay, well, let me ask you this, because we talked about this before. Sugar. I remember years and years ago, I really thought it was a myth. You know, people say stuff. But I realize now that it's not a myth. What is it about sugar and cancer? What is that link between excessive amounts of sugar in your diet and cancer?
I think it's related to indirectly through IGF-1, because sugar mainly excess calorie, and then it increases this hormone to the point that it induces cell to proliferate. Now, we don't know that clearly, but we'll start learning more and more. There is a group of Jewish descendants in South America that develop Laron syndrome, and they have mutations that have IGF-1 receptor defect, and very few of those people develop cancer. So it becomes protective. You brought up a very good point. Sugar is not just sugar. Sugar, there are different types of sugar. The sugar that we call glucose is the type of sugar that could be used in all our cells, from your brain, your muscle, your skin, all could use it. The fructose is very difficult to digest, and mainly in the liver. And majority of our fructose coming from high fructose corn syrup that is produced from corn and now being used in all soda, juices, and many products, cakes, ice cream, things like that. So it has replaced pure sugar with additional of fructose. And what's interesting about fructose is it's mainly digested in the liver. So when you eat all this juices, drink juices, and sodas, your liver basically get bombarded by a tremendous amount of fructose. And some studies suggest that all it could do is just convert this excess fructose into triglyceride, into fat, into uric acid, which causes gout. So be careful. Those sweet stuff are not all equal, and some of them are worse than the others.
Okay, well, let me ask you this, because I'm at a point now, Dr. Santoso. I don't eat a lot, but I do try. I have a nutritionist at the VA, so I make sure that the little bit that I do eat, that I'm eating the right things. But how do you get around eating the fructose or whatever it is if it's in everything?
I think if we get less processed food, you have less of those high fructose corn syrup derivative. So anything you get from the ground, fruits, vegetable, fresh, not canned, I think you lessen your risk of getting excessive fructose.
Okay, because I was just going to go into that about the processed foods. Name some, if you will, some processed foods. If you was going to say, stay away from this, and that, what would be on the top of your list? What would you not have at home on your table tonight?
Practically, if you go to the grocery store, outside the grocery part, I think those are dangerous territory. Yeah. Now, you could have some, but we as people tend to eat excessively. I would, at the risk of being chastised, I would say soda are not healthy.
Okay.
Juices in general are not healthy. This is my personal opinion. If my patient asks me, could I drink orange juice? I say, eat orange, not the juice. Why? Because many of them are sweetened by fructose-based sweetener.
Well, what would be a good substitute, say, for someone like me that have one of those bellies that when I eat oranges, I get a stomach ache. Oranges give me a stomach ache. I don't know if it's the acid. Apples give me a stomach ache. If I eat too many bananas, I get a stomach ache. So I do a lot of grapes. So what would be because I'm not going to do the orange juice. I don't do juices, don't do sodas. What would be a good alternative to oranges if I like oranges, not to have to suffer for eating an orange?
Well, we are fortunate living in Mid-South because our pretty mild climates, we do get variety of fruits. So you have to, like what you're doing, you try one over the other. Okay. And in general, I think moderations will be advisable.
Like a slice of orange and not just sit there and do the entire orange.
Correct. We don't have to. The good thing is if we have variety, our food should be like a rainbow. Okay. So it has different color, and that's where you get tremendous amount of vitamins.
Okay. So what nutrients? Let's talk a little bit about nutrients, because in just a little while here, we're going to talk about a seminar that you will be the, I guess I would say the speaker, and you'll be talking about. It's free. It's about overweight and cancer and how to prevent it with good nutrition. So how do we get good nutrition? And we talked about this a little bit too before on part 1 of this series. When you're poor and you can't afford to eat well, what do you do?
I think things that you cook for yourself, you have more control.
Okay.
Yes, it does take more time. But in the same times, I think if you plan it well, you could control both the cost and the time. Again, I understand in some circumstances it's quite difficult. It's when we go outside, go to restaurant and so on. Now, we could do that occasionally, but when we do that too frequently, we have no idea what's being put in there. Now, there are more and more restaurants are putting calorie and nutritional contents into it. I think that's a very good trend to do. So I would still base on cook yourself, you know what you're doing, and try to use as fresh ingredient as possible. Things that already been packaged by men or women out there are cause of suspect. Okay.
Let's talk a little bit about, because this is important as well, and I'll cover that I'm pretty sure on next month's show with the cardiologist, but salt. How bad is salt intake?
I think we're taking salt. We as Americans eat too much fat, too much sugar, too much salt. I'm as direct as I could be.
Okay, but...
And too much calorie as well.
Yeah, but why? I mean, why? I know it's obviously makes the food taste better, but you used the word the last time, acquired taste. So I have learned to acquire the taste, but not having to have it. I remember years ago, because I didn't know any better, I would put salt, just put the food on the table, you automatically grab the salt shaker.
Correct.
Without even tasting it. But now I don't.
Good.
I try to cook at home. I'm not really a cook, but I would prefer cooking at home because, number one, most people, when I look at these restaurants, at these workers, they don't wear gloves, and I got this OCD about, people touching my food. So that forced me now to throw it together at the house, and I feel better because I know it's clean and it's good. But if going back to for the people who cannot afford still to eat healthy. And I think it's really a trend now. A lot of mothers work, and you have a lot of single mothers. My mom cooked, and I was fortunate to have a grandmother to live in the home with us until she passed away. So there was always an adult there, which meant we always had home-cooked meals. And I think it made the difference in my life today. So still, what do you do when you're poor? You can spend $2 and go to the fast food and almost feed the whole family with $10. So what do? What are those people going to do?
It is difficult. I acknowledge that. Recently, my wife and I volunteered to babysit 4 girls from 2 years to 10 years old. And we realized how difficult it is to feed them healthy. It's just so tempting to just take them to burger on the corner, and then they'll be happy with the toys included in there anyway. But we strive very hard not to do that. So we plan. We plan the week before, because they stay with us for a week, and what they eat step by step. And it is hard. It is hard. I have no doubt a single mother, single father will have difficulty. But in the same time, you mentioned that cannot afford, but I say cannot afford not to do it, because you set the way they eat for the rest of their life. If as a child, I am used to eating burger and fast food, I will do that for the rest of my life. But if I were as a child being conditioned to eat as healthy as possible, maybe not as enjoyable, then I become selective in that particular case. So yes, you cannot afford, but at the same time, you cannot afford not to.
That's the key. Because honestly, since the last show, when you was here, we talked about water and the importance of water. I also now, I used to just do Cheerios, but now I go to the organic section. It costs a little bit more, but it's just me. I'm like, it costs too much not to do the right thing. So I buy I think what's it called? It's I believe it's whole grain cereal. Costs like about $4 a box, but they have all this stuff in it. You got the almonds and all this stuff. The box is so heavy because it's actually loaded with what I need.
Good.
So I don't buy just the regular Cheerios anymore because it didn't give me all the nuts and the grains and the fiber. So just everything I buy now has extra fiber.
And you could also add bananas. If you could eat bananas and strawberry, other thing into the Cheerios, so it's not just carbohydrate and sugar and milk, but also mixing with fruits.
Okay, just being creative.
Correct.
Okay, that's the main thing. Let me go back to a gynecologic question about young girls. Because a lot of our young girls now are way overweight. And it seems to be a trend. The bigger you are, remember we talked about that, the bigger you are, the finer you are, and the guys like it. I don't know if they like it because if they think you're overweight, you're cooking. So I don't know, what the dynamic is for that, but it's working.
Correct.
Okay, because women are not trying to change it. So when girls are young and they're overweight and they're not losing any weight, which means more than likely if you're overweight as a child and you don't make a lifestyle change, what's going to happen to that young lady as she get older as it relates to your practice, gynecologic cancer?
I think putting her at risk significantly for uterine cancer. I'm seeing younger and younger women now with uterine cancer. Uterine cancer is supposed to be a postmenopausal disease, but now I'm seeing age 35, 37 years old developing uterine cancer, and I have to do hysterectomy as a solution, which is unfortunate for a young woman to lose their reproductive organs.
Okay, speaking of that, let's talk about post-surgical pain for a patient that is overweight. Let's talk about that and the differences in how the different procedures, surgical procedures that you use and why.
Sure. Being overweight complicates many things in medical care. before surgery, during surgery, and after surgery.
Okay.
Before surgery, usually many patients who are overweight have comorbidities such as diabetes, hypertension, that put them in more difficulty during surgery. So we have to clear those up. We have to control their blood glucose. We try to control the hypertension. Many of these diseases will be resolved completely with losing weight, but it's easier said than done. During surgery, it's more complicated in terms of positioning the patients. Doing the surgery, it increases more blood loss. Organs are more difficult to access because of the depth and the size of the patients. Post-operatively or after surgery, patients at higher risk of wound complications, sleep apnea, aspiration, pneumonia, blood clot that could go to the lung and people die very quickly, called DVT and pulmonary embolism. So overweight making our patients more prone to complications.
Okay, well, so how do you all get in there? Say like if you have a patient, just hypothetically speaking, say with a 40 BMI, maybe 300 pounds or whatever, and got, the stomach, how do you get in there to get the cancer out? Isn't that a challenge?
It is. Let's talk more specifically, say uterine cancer.
Okay.
We have developed now more and more minimally invasive procedure. That means we make small hole, we use a scope, almost like a camera going in, and we could try to do surgery laparoscopically or using a robot to help us assist doing the surgery. That's helpful in the sense that incision is small and they recover faster. The only dilemma is not all patients could be operated that way. For example, patient that has multiple surgery, putting them at higher risk for complication. In addition, patients with cancer that are large or already spread, we cannot do that procedure because we can't remove as much cancer doing it that way. Thus, it's confined to certain specific populations, so we use minimally invasive. In patient that has the cancer already spread to other organs and the uterus is very large or the cancer become very large, you cannot deliver that using a small incision or through the vagina. So we have to open their abdomen up and down. And to do that, it will usually pertain increased length of stay, more pain, and so on. And because of my interest in trying to improve the quality of care in terms of post-op pain, we have done research that our research has just been published in 2015 using what we call multimodality pain control. What's that mean? That means we're able to decrease pain markedly instead of just using conventional morphine that we usually do.
This clip that is being queued up is the reason why 4 years later, I'm still doing medical talk. Because what I learned from you that day was that show was just one of those happenstance things. It was going to be for one day. Christian Brothers allowed me to have the little theater free just to come in and do a show about cancer. And I heard about this Dr. Santoso, and I thought it was going to be, okay, this is medical, so it'll probably be boring, but I'm going to do it because my sister died from cancer. I'm going to do it for her. But this one clip is the reason why 4 years later, I'm still doing this show, because you made it not only educational for the audience and myself, but you made it fun.
So, Dr. Santoso, obviously you're not going to leave the stage until I find out how does the men get it in the first place.
I'm blushing.
Yeah. Because how can we stop something that we don't know where it comes from? That, to me, that's scary.
I did too, because I'm like, oh my God. So that was really the setup. And at that moment, that was when I knew that medical talk is what I want to do for the rest of my life, because that one little segment made it so much fun. You showed me that, because that whole show was good and we learned a lot. And I'm going to play that entire show back because you covered a lot about HPV. But I want to thank you so much for being my medical mentor. And I can say again, and I can't say it enough, because of that, you're coming out on your birthday, and just that experience, I feel like that was God's calling me to do a medical show and keep it plain and simple. And thank you again, Dr. Santoso.
Thank you. The pleasure always mine.
Thank you, as always. It was wonderful. My special guest, Dr. Joseph Santoso.